Now we will start our session for today, and the session for today is the common orthopedic problems that are prevalent in the geriatric population. We are starting from the subject of orthopedics for two reasons. One is because it is so very important, as you know, that one of the most important problems that elderly face is that of mobility, is that of joint pains during their old age, and second is that during your first spell which you are going to have, orthopedics will also be one of the departments in which you will be posted. So it is better to have an overview of the problems that are prevalent and how to go about these problems, how to go about examining the patient and assessing them. For this purpose we have taken up this topic today. I would request Dr. Dhal now to start his session. I would also request him that since this is the first time that we are having an academic session with you, I would like him first to elaborate how we should take the history from a geriatric patient. As we all know, geriatric population have got different characteristics than a normal adult population, and I would like him to stress on the points that we must keep in mind while taking history of a geriatric patient, not specifically a person who may be suffering from orthopedics problems, but a geriatric patient in general, because as I already told you in the first session that we all know geriatric population and geriatric patients or elderly people, they suffer from more than one problem. So the history taking in any of the subjects, the basic criteria, the basic principles will remain the same. Along with this, I would also request him to bring out the salient points that we must ask and we must keep in mind while taking history of a geriatric patient. For example, a particular symptom that he may attribute to a system, say orthopedics system or musculoskeletal system, may have its origin or may have its root in some other disease or in some other disability. So I would request now Dr. Dhal to deliberate on first the principles of history taking, how they are different from the history taking in a normal individual, and then secondly what are the points that we must try to bring out in a person who is in the geriatric age group. Dr. Dhal.
Thank you, Dr. Ruchika. Before we embark upon the history taking part of this session, I think one needs to know why tackling the geriatric population has become so important to the clinicians in the Indian subcontinent. I think previously it was thought that it is the Western world which needs to concentrate on the geriatric population. But now we are seeing that even in our own country, the average lifespan of an individual is increasing. The average lifespan of an Indian today is almost nearing 70 years, and with this we also are gearing up to encounter a gamut of orthopedic geriatric problems. And these problems are not only a problem for the patient, but it is a problem for the state itself because of the obvious costs involved. And it is but natural to do a rethinking or to have sessions of thinking whether to allocate a large part of the resources to the aging population or to concentrate on the young, productive lifespan of a young person. I think that debate will go on, but as clinicians, our prime responsibility is to make the elderly as comfortable as possible. With these remarks, I think we need to now address ourselves to the one of the basic methodology of arriving at a diagnosis, which is the history taking. As Dr. Ruchika pointed out, that it is no different than any other patient. Orthopedic patients also the same technology of history taking is to be followed. But one must remember, and it needs to be emphasized again and again, that the geriatric population has possibly multiple concomitant comorbidities, as they are known as. These patients may be having diabetes mellitus, they may be suffering from high blood pressure or hypertension, they may be having visual problems, and so on. And it is not only important to concentrate on the orthopedic problem which this patient has, but also to address ourselves to these multiple problems which this patient has, and which for some reason may not have been detected till the time this patient has a fracture or starts having a backache and presents to the orthopedic surgeon. The first and the foremost, obviously, when the patient arrives, you have to ask him what brings him here. And this is what is known as the presenting complaint. And with the presenting complaint, supposing he tells you that he is unable to walk since yesterday. What made him unable to walk? The next question, and he comes out with the answer that he stumbled in the bathroom and ever since he is not able to walk. A mere stumble, not a fall, or a stumble leading to a fall can also result in his inability to walk, and this should trigger the thought process that probably this patient has had some sort of a fracture or a dislocation. And as you are all aware that the bones in the geriatric age group are soft, they are osteoporotic, and many a times it is difficult to say whether the fracture caused the fall or the fall caused the fracture. Nevertheless, once you have a history that the patient has had some sort of a stumble or a fall, the obvious reasons for diagnosing this as some sort of a fracture are already there. Along with this history, one needs to talk about whether this patient has any symptoms of other illnesses. And as I have already told you, you need to do a thorough probing. Remember, your patient who is a geriatric patient may not be as alert as the younger individual. He may not be forthright in bringing out the complaints. So you have to be patient with him, over patient with him. You have to sort of coax him. Do not you have to be a good listener to him, but at the same time you have to channelize his thoughts in one direction. Do not let him go astray. And this is a very, very important part of the history taking.
Dr. Dal, I would also like to interrupt here and ask you that see, most of the geriatric patients, they will come up with a very, very long history कि हमको 5 साल पहले ये हुआ और 7 साल पहले ये हुआ और 10 साल पहले ये हुआ और 11 साल पहले ये हुआ. At what level, till what level do we have to consider that the history is important? I mean, and at which history do we think or we have to consider it irrelevant, or do you feel that all the history is relevant? I would like you to deliberate on this.
All this clinical acumen and the acumen to take good clinical history would come by experience, and that is why it needs to be emphasized that whenever you are with your trainers or you are at the resource centers in the hospitals, do utilize this time to interview more and more patients, to examine more and more patients, so that you will develop that knack, and you will also be able to filter out the confusing or the false information which is coming in. But at the same time, my advice initially to the uninitiated is try to take everything into account. Do not snub the patient, because he may just get discouraged. He may not tell anything. So try to encourage him to tell whatever he wants to tell, and at the same time, with your maturity and with your experience, try to steer him towards the relevant history. To give you an example, if a patient has backache, and with your knowledge of what all needs to be elicited, I think you need to elicit whether the backache is radiating nature or not, whether it was triggered off spontaneously or it came with some sort of an injury, whether there is a pre-existing history, whether he had similar episodes in the past or not, and whether with coughing and sneezing this increases or not. So these are the relevant points, and one can keep on asking these relevant points if they are not being brought out by the patient. But at the same time, if he starts saying that I have a pain in the toe which goes up and it goes up to the head, then we know that this sort of a description is haywire. It has no scientific explanation. So while we are listening to it, we try to steer him out of this. So this is how one can manipulate the interview to be able to arrive at a particular. You try to gather the relevant information and do not allow the patient to go astray, and at the same time the clinician would obviously go astray if he just listens to everything which the patient is offering.
Dr. Dhal, as you are saying that we must listen very patiently to the patient and we must try to note all the points. Now, in addition to that, do you feel that there are certain questions that we must ask a patient in this age group to bring out certain problems which maybe he feels that they are part of old age, because he plus his family may just, whenever he brings up a complaint, tell him, ye to is umar mein hota hi hai, this is normal aging process. So, but we know by our knowledge that there are certain things which are not by common sense as aging process, but they are a reflection of pathology. So, do you feel that there are certain questions which we should ask from our side so that they reflect what problems he may be suffering from?
I think you have brought out a very relevant point, that sometimes the relatives do say ki this is a normal process of aging. They have their own impression about the disease of their parent and all, or they may just brush it aside that he just keeps on imagining things. I think here I would like to emphasize that these patients may be hard of hearing, and some of them do use a hearing aid. I think it is important to have a one-to-one dialogue, because some of these geriatric patients, or majority of them, are highly intelligent people, and we are just because their mental faculties have dulled, they are not able to communicate. So to be able to communicate, if he is using a hearing aid, insist that the hearing aid is installed, it is on, the battery has got a good charge, so that you can directly communicate with him. If his eyesight is not good, let him have his spectacles there. I have seen patients saying, relatives saying that we have left the hearing aid home, we didn't know that it is required since he was just complaining of pain, and we can give you all the information. I think if you really want to get at the root of the problem, it is important to communicate with him. Let him be able to see what your body language is, what you are. Sometimes he may like to look at your lip movement and understand what you are trying to say. So all these factors, which probably are irrelevant in the younger age group, have a lot of meaning in the older age group.
I think that is a very important point, Dr. Dhal, because we have seen that now with the elderly abuse on the rise, elderly abuse both by abusing as well as by neglect. I mean, even neglect is an abuse. So I think it's very important that we must take the history from the elderly, maybe in isolation, and supplement it by the history from the family or from the caregiver, whoever may be living with the elderly. I think that is very important, so that we get the complete picture.
Yeah, that's exactly what you have said is absolutely right, because people who are observing this particular patient also have a lot of good information available with them. once we have embarked upon and we have elucidated the salient features of the complaint, then like any other history taking, we have to note down the complaints in a chronological order, meaning thereby the most recent complaint is the foremost and then the others are followed by. History of past illness we have already talked about, that we need to know whether the similar complaints are recurring, and which is very common with the degenerative process which majority of these patients do suffer from. A pain in the back, a pain in the knee, every winter month this pain may be coming back, or every time this patient is overusing or overexerting, this pain may come up. The other symptoms like claudication pain. Elderly age group, very fond, these patients are very fond of going for a morning walk or an evening walk, and they may come up with an additional history that this backache comes up only when I am 2 kilometers down the line and I have to sit down for 10-15 minutes, then I can walk the same distance again. Now this is very much suggestive of a spinal canal stenosis occurring because of a degenerative spinal problem. So all these are clues, and unless the clinician is aware of what to elicit, he should be able to know whether this is claudication pain, whether this patient is a smoker or not. Similarly, the claudication pain can also be due to something called Berger's disease, and elderly patients also smoke. They have been smoking the entire lifespan, and at some point of time this patient may start having claudication pain. So once you have this sort of a history that there is some sort of claudication, then relevant history is whether this patient is a smoker or not. If he is a non-smoker, then Berger's disease or small artery narrowing is totally out, and we are probably narrowing down our diagnosis to a degenerative spine with spinal canal stenosis. So these are examples of how the complaints of the patient can lead us to our asking them leading questions to be able to elucidate finer points in the history. Then corroborative history or other history to rule out other problems like claudication pain or canal stenosis can also be due to neoplastic problems, and the most common problems of neoplasm can be secondaries in the spine, and secondaries in the spine may be from some primary which has not been detected till now. So try to have history whether this patient is of late he started getting exhausted very fast. There are patients who say that I was able to walk 4 kilometers. Now when I go for a walk, after walking for 1.5 kilometers, 1 kilometer, I just get exhausted. I want to sit down. So this patient may be anemic. He is losing blood from somewhere. Maybe there is a GI malignancy which we are missing, which everybody has missed till now. And by the way, we all know these malignancies are very, very difficult to detect in the initial stages. So all these additional features also need to be questioned. The patient needs to be questioned. What is the color of the stools that he is getting? He may volunteer that he is of late he is getting black stools. So this triggers something in your mind that maybe we are dealing with a malignancy in this patient.
I think Dr. Dhal, another one very important area is probably the pharmacological history or his drug history, because there are many manifestations that he may be having because of drug he is taking since many years. So I would like that if you can elaborate a little bit upon that also, that which drugs that we must or how we should ask about that history.
Yes, I was leading to that only, but you have raised a very relevant question, and we all find grandmothers, grandparents carrying a separate thali or a bag, which whenever they move around, which has umpteen number of pills and capsules and vitamins all merged together, and they are in the habit of having a handful of oral medication at a time. So it is very important whether this patient has been having some long-term medication. It may be for his aches and pains, analgesics having been taken for years together, and they may be creating some side effects also. They may be taking some sort of a steroid for a long time. It is not only that this drug has been prescribed for a long time. I have seen in the elderly that they sort of use their native intelligence. Since they do not have access to the treating physician all the time, because the children are busy, because nobody can take them, they develop their own native intelligence that last time when I had a similar pain, I was prescribed this medicine, and they would fish out that medicine, take it on their own without telling anyone. So
I think the dosages also, they tend to vary, that we are having
yes.
a bigger problem, let us take 2 tablets, or we are having today the pain is less, so let us just skip the medicine.
Exactly.
Even for BP and all, that today we are not feeling, because they have to take some of the drugs for a very long time. So I think what you are saying is very important, because sometimes they skip medicines which are most important,
yes.
and sometimes they may overdosage themselves also.
And again the same phenomenon, a person who has hypertension, he may say that initially I was prescribed drugs, but now my blood pressure is all right. So this is how the geriatric population is special. It's special. It has got its own whims and fancies, and the clinician needs to acquire special skills to derive the correct history for these problems.
How important do you feel is the family history in such a age group?
Well, family history, like in all other problems, has its own importance, because there are patients who come and tell us that my father had a similar problem. He also used to have pain in the knees. He also started getting crouched in the spine, and so familial history is important, but I think it is less important than in the pediatric age group, because there there is much more importance in knowing how this disease is going to evolve. But at the age of 70, 75 years or 65 years, the evolution of disease has already been taken. If there is anything which is hereditary, it must have already been obvious. Like take for instance patients having ankylosing spondylitis. Now the disease comes up in the 20s or 30s, and it's already burnt out by 50, 60 years of age. So it becomes irrelevant at that age, because he's already, all the stigmata are now well developed and it's not going to progress. So it is important, but probably the relevance may not be that much. So it's probably the clinician can devote less time
on
that, and rather devote more time in elucidating the relevant history for the problem at hand.
I think another one important point that we should stress is that since they have a very long, years, 50, 60 years of life, at least when we start considering them. So the events that have occurred, it may be related to medical, maybe traumatic, whatever, it is difficult for them to tell how many years. So I think the better it is to ask related to a particular event, that maybe there was an epidemic, whether it is near that year, or whether there was some event which had occurred. According to that, if we ask when your illness had started, so I think then we can pinpoint the exact time or the exact date, the exact year when their problem had probably begun.
I think this is quite relevant for the rural population, or the underdeveloped or the poorer population, because they have invariably I have demonstrated in the clinics that whenever you ask this patient, the patient may be looking 70 years old, you ask him, he says I am 45 and then you ask him, when did the counting begin? From which year are you counting? When were you born? He says that I don't know. So it's a very relevant thing that, but if you ask him, were you born before independence or after independence, he may be able to sort of give you a clue. It gives you a clue. So that is how history can be elucidated. And I think we also must realize that we need to devote some time on taking the psychological history. Because majority of these patients, they get depressed. It's not only we were talking about geriatric abuse, and I think neglect on the part of the children or the grandchildren, in spite of the fact that the grandparents are staying with them, just the fact that the son and the daughter-in-law, they come home, they just go to their room, they don't talk. I think that also is neglect, and this patient becomes reluctant to tell his complaints. All day he has been suffering, but when the children come home, he is reluctant because he feels that they are tired. If I tell them, they would be more stressed out. So he just lets the thing linger on. I
think that history is very important from the point of view of management also. Because when we have to consider that what type of treatment has to be instituted to him, we have to see what kind of social support, what kind of family support he is getting, because in terms of finances, in terms of maybe even help that he may be getting, the children may not be in a position, or he may not be staying with his family so that somebody can take him to the hospital. So then our management probably will completely change.
And antidepressant therapy and all those things also need to be, maybe some counseling is required on the part of the psychologist. Unless we do that, we don't get the desired result. You may do excellent surgery, but this patient is depressed. He would refuse to budge from his bed.
I think we have had a very exhaustive talk on how history should be elicited, though I think we discussed this for a longer time, because this is the most important thing. Whether you are considering the examination of any system, taking the history of any system, your attitude towards the patient, your way of eliciting the history is most important for us to go ahead for any clinical assessment. Now, Dr. Dal, I would like you to elaborate similarly some points on the examination. First on the general physical examination, and then examination specifically we could take up the musculoskeletal system. But first let us consider the general physical examination, because like history, there are many features in the general physical examination which may be indicating particular diseases, which again, as the individual may be feeling, and we also may sometimes have our perception that this is a normal aging process, though it is not. So I would like you to just elaborate on some of these points.
I think general physical examination, as known in the orthopedic parlance, that he usually like to do a complete head to toe examination, and the relevant things like you like to see the conjunctiva, you want to gauge whether this patient is anemic or not, what is his nutrition like, is he dehydrated, because many a times we find that elderly age group patients, when they are admitted in the emergencies or in the following a trauma or following an acute episode of backache, you get their blood urea test done, and it comes out to be abnormally high, and you talk to the medicine specialist, and he says that you push in some saline because this patient looks dehydrated, and you start IV alimentation and he starts improving. So it's important to detect in general physical examination all these small little things, because this patient may not be able to volunteer information, so you have to pick them up on your own. It needs to be emphasized that proper exposure of the patient is very important, because we have seen, especially during the winter months, one feels reluctant to take off the blanket and examine the patient, and umpteen number of times we have found that so many important points have been missed. So please ensure that you have a blower or a heater running, make the patient comfortable so that you can expose him properly, and do a proper head-to-toe physical examination. Try to elucidate whether there is any swelling, abnormal swelling anywhere in the body. Try to see whether there is any lymphadenopathy. What is the type of lymphadenopathy, whether it is discrete, whether the lymph nodes are matted, or whether there is any separation in the groups of lymph nodes which you are examining. Along with this, you also need to do a good examination of the chest. Try to auscultate the chest, try to look for any discrepancy in the respiratory movements, because we all know with our knowledge that any malignant pathology, any infective pathology can also affect the respiratory system. Coming lower down, must do a good examination of the abdomen. Being orthopedic surgeons, these things usually take a backstage, but in the elderly age group, I think we must do a good physical examination of the abdomen, do a good palpation. All 4 quadrants must be palpated individually. Any lump, obvious lump or a doubtful lump, must be recorded on the chart, and it should be probed further. When the patient is being investigated, this should be kept in mind, and relevant investigations should be done to rule out any serious problem there. Coming lower down, again we have already discussed that the extremity pulsations must be palpated, because we all know that at this age the blood vessels are becoming atherosclerotic, and we need to know whether there is good pulsatile flow in the limbs or not, or whether a part of the problem is attributable to decreased circulation. Also try to look for any non-healing wounds or ulcers. These patients who are diabetic, they may be having peripheral neuropathy, which they are not aware of, and they may be having some small little ulcers in the great toe, in the plantar area, which they are not able to look at, and since they do not have much of pain, they are totally oblivious of the fact that these things are existing. So these are also important
I think in
as
short,
far as general physical examination is concerned.
You want to stress that unlike in an adult, all the system which is he is presenting with the problem, that system must be examined thoroughly, and in addition to that, all the other systems must also be browsed through, or must be at least we need not go into the details of those systems examination, but they also must be assessed to see any similar problems or any associated problems which the elderly may be having.
Definitely. And once you have done a good physical examination, good general physical examination, then you are now geared up to look into his presenting complaints and to narrow down your examination to the concerned system. This system may be the knee, the hip, the spine, the shoulder, whatever he is complaining about, and then your local examination would be guided by the recommended methodology for that particular system.
So, Dr. Dal, if it is possible for you to summarize how we should do the detailed musculoskeletal examination, because they will be doing this in the practicals, but the tips and the important points that you feel must be kept at the back of the mind while doing this examination, I would like you to elaborate them.
Okay, let's take one by one. Let's start with the spine, because patient complains backache. He says he's got backache. So this patient should be examined first in the standing position if he is walking around, and ask him to do a simple test. Ask him to try and touch his toes without bending his knees, and let him go as far as possible. The moment he starts having pain, you ask him to stop, and try to gauge how much of distance is there between his fingertips and the floor. Just record it, because normally a young individual should be able to do that fully. He should be able to go all the way, but in an elderly age group, we expect that he would be short by about, say, 10 to 12 inches off the ground. If he is able to do up to that, he is quite alright. If he does not have pain in this particular movement, then we know that by and large his dorsal lumbar and lumbosacral spine are more or less normal. After this, he should be made to lie down. He should be made to lie down in the prone position or in the lateral position, whichever is more comfortable to the patient. And one should try and palpate the spinous processes and try to rotate the spinous process. All this would be demonstrated in the clinical postings. But the thing is that one needs to palpate the spinous process, put a little pressure and try to rotate it towards the opposite side. If the patient winces, this means this particular segment is tender. Try to identify which particular spinous processes are tender. The guideline or the clue is provided by various landmarks around the spine, like the highest point of the iliac crest corresponds to the disc space between L3 and L4. Similarly, the inferior angle of the scapula corresponds to 7th dorsal vertebra. The vertebral prominence, which is the C7, is another landmark. So depending on whether the pain is in the dorsal spine or in the lumbar spine, you can take the relevant clue from one of these landmarks. So once you know which particular area is tender, you try to see whether there is any swelling, any obvious swelling in the paraspinal area or in the region of the iliac fossa, because infections, which are again very common in the elderly age group, something like a tubercular abscess can track down into the iliac fossa, a psoas abscess, we all know. So all these relevant examinations should also be done along with the spinal examination. And once you have looked for the local areas, you also need to do a good neurological examination of the both lower extremities. You first try to gauge whether the tone is increased or not. Thereafter, you try to evaluate the muscle power. If you find that there is any spasticity and the muscle power is gone down, you need to evaluate the reflexes, the deep tendon reflexes, whether they are exaggerated or not. Try to do a sensory examination in the end, along with superficial reflexes, and taking the entire data, you have to sort of arrive at a diagnosis. Not only at a diagnosis, but also try to figure out or analyze what is the neurological level of this patient and what is the vertebral level. Because we all know that in the dorsal spine, if the vertebral level of the tenderness is at, supposing, D8 level, the neurological level should be correspondingly at D10 level, about 2 vertebral levels below. So try to see whether the neurological level, which is arrived at by the neurological examination, both motor, sensory and reflex activity, try to see whether these two are corresponding or not. If they are not corresponding, then probably we are dealing with a skipped lesion, so that also needs to be elucidated. Then we come to the examination of the hip joint. As far as the hip joint is concerned, these patients, again, there is a complaint of majority of the times the hip problems are related to trauma.
I think I am getting your time is running out. So for this session, I am very thankful for you for patient listening. Please come up with your questions, which we may take up in the next session, in which we will continue our examination and the common problems encountered. Thank you.
Thank you.